Well, good evening, everyone, or afternoon, depending on where you're at. My name's Mary Ballacher, and I'm the co-chair with the Forum for ESRD Networks, and I'm the co-chair for the KPAC. And with that, I'm really pleased to have you all here. It looks like we have about 26 people so far, and we have a great lineup of speakers this afternoon, this evening. So I'm very excited to start out. I'm not going to spend a lot of time with introductions. We had some slides at the very beginning. Hopefully, you had an opportunity to check out those slides. But we're first going to start with our first amazing guest speaker, Dr. Sam, and then we will actually hear from some patients that are going to kind of tell you, and a caregiver as well, about their journey with home dialysis. And if you have questions, please feel free to put those in the chat. That'll be a great opportunity when we complete our presentations that we'll have time for as many questions as we possibly can within that time frame. So again, welcome. And with that, I'm going to turn it right over actually to Dr. Sam.
Hi, good afternoon or good evening, depending on where in the country you are. I'm gonna try to share my screen so I can pull up my slides. And I just want to really thank Mary for the invitation. I'm really excited to be here, and I'm really excited to hear the patient presentations later on and hear their stories. And I just go ahead and start out. I will. So the agenda, my talk will be divided into, at first I'm going to talk a little bit about how hemodialysis and peritoneal dialysis work. Then I talk about a little bit about how is peritoneal dialysis performed, which I'm sure a lot of the audience already knows about it. But maybe I'll just add a few things. And then I'll talk about a little bit about home hemodialysis, how it's performed, and then I'll talk a little about the benefits of home dialysis. Let me see if I can. Okay, so there are two types of home dialysis, as I think everybody knows. There's peritoneal dialysis, which happens after a catheter is put into the abdominal cavity, and then it's connected to a solution. The fluid gets drained and new fluid is put in, and there's hemodialysis, and at least a couple of machines that are used for home hemodialysis in the United States. This is the next stage machine. It's a fairly simple machine, and the patients are able to do hemodialysis at home with this machine, which enables them to avoid coming to the in-center dialysis unit. So the uptake of the different dialysis modalities, this is as of 2018. In-center hemodialysis constituted by 87.5% of all dialysis done in the US. Peritoneal dialysis was 11%, and home hemodialysis is fairly uncommon in the US. It only constitutes around 1.5% of the outpatient dialysis that's done in the US, and we're really hoping to increase these home numbers in the next few years. I think as of today, these numbers are probably already looking better, but our goals would be to have at least 25% of patients on home dialysis in the next few years. So the way peritoneal dialysis works is the fluid goes in the abdominal cavity, and the peritoneum and also the intestines, and they have a lot of blood vessels that run very close to the fluid that's in the peritoneal cavity, and toxins such as urea, creatinine, other things diffuse from the blood vessels into the peritoneal cavity across the membrane and into the fluid, which is the dialysis fluid. And when the fluid is taken out of the abdominal cavity, then all those toxins are removed In addition, there's usually these fluids contain a lot of dextrose, which is glucose, or sometimes icodextrin, and that because the osmolarity is higher on this side, then water moves from the lower osmolarity to the high osmolarity solution, and fluid is also removed when patients get the dialysis with the peritoneal dialysis. And you're all familiar with how the peritoneal dialysis catheter is placed. It can be placed in multiple different locations. This is on the right side. And there's a Y system set up here, and this system is very important in decreasing infection. And the point of this would be to flush before you fill. So if you the old system, which was used many years ago, 30 years ago, the fluid would go back after coming out of the patient, and then some of it will go back when you use the fluid, and that caused the bacteria that's in the catheter to go back in the patient, and the risk of infection was much higher. But this vice system has really decreased the incidence of infection. And you can see some of the machines that are used at night for automated PD. So how hemodialysis works, this is true for both in-center and home hemodialysis. There are lots of things in the blood as listed here, and I didn't list everything obviously, and there are certain things that are added to dialysis, dialysis fluid in order to prevent them from loss of those important uh, electrolytes or whatever else they may be when patients are doing dialysis. So for example, sodium, we don't want to lose a lot of sodium with dialysis. That's not safe. So we put the same amount of sodium in the dialysis fluid as it is in the blood. So that way sodium does not diffuse out. So there's a membrane in between the in the dialyzer where the patients are getting dialysis, and there's a semi-permeable membrane here that allows some things to pass through and not other things to pass through. The small things such as sodium are very freely permeable, go to the other side. So this is how we remove potassium, for example. So the potassium in the blood is often even a lot higher than 4.5. And the amount of potassium in the dialysis fluid can be controlled, but usually is around something around 2. So when patients are dialyzing, that potassium moves from the higher potassium concentration in the blood to the lower concentration in the dialysis fluid. And bicarbonate, is often patients on dialysis are unable to excrete the extra acid. So we put more bicarbonate, which is a base. So this is how we fix the acid problem with dialysis. We'll give them more base because there's more bicarbonate in the dialysis fluid than in the blood. And then toxins such as urea, creatinine are removed, and they're pretty small. There's about the same amount of sugar in the dialysis fluid as it is in the blood. And then, the phosphorus is also, there is no phosphorus in the dialysis fluid, so we're trying to remove as much phosphorus as possible. And things such as albumin are just too big. They don't go through this membrane at all. So there's no loss of albumin in the hemodialysis machine. So, and I'm just going to go over this really quickly. So with hemodialysis, how much toxins are removed, it depends on how fast the blood is flowing, how fast the dialysis is flowing, the dialysis fluid is flowing for, let's go back here. So how fast the blood is going this way, how fast the dialysis fluid is going the opposite direction. That depends how much toxins we remove. It also depends on how big is the surface area of this dialyzer. So how much area is there for exchange to happen. And it depends on how permeable, like things that are really big like albumin, there is no removal of that substance because it's just too big. With peritoneal dialysis, the only thing that determines how much toxins is removed is how much fluid is coming out of the dialysis fluid. So how much fluid is put in, how much fluid is coming out, it determines how much toxins are removed. So if you do 10 liters, then that will be doing more toxin removals than doing 8 liters. That peritoneal dialysis can be done in two different ways. There's the CAPD, which is the manual peritoneal dialysis, and often patients do it 3 to 5 times a day, most often 4 times a day. Usually the exchanges themselves take about 30 minutes, and the fluid bags are 2 to 3 liters each. The automated peritoneal dialysis is a machine at night. It is done over 8 to 12 hours every night. There could be a day exchange also, or there could not be a day exchange. And there's about 8 to 10, 12 liters per day, which comes out about the same as 2 to 3 liters back every 4 times a day. The home hemodialysis, patients often have the freedom to schedule their dialysis, what time of the day they're doing it. A lot of times, which days of the week they're going to do it. Whereas, with in-center dialysis, they have a fixed schedule where you have to come at this time to dialysis and get dialysis at that time. The home hemodialysis is also done usually with a graft or fistula. Patients can do dialysis at home with a catheter, but usually it's done on a temporary basis because catheters often cause are a higher risk factor for having infections. In the US, there are two machines that are used commonly to do home hemodialysis. Is the next stage and the Tablo machines. And machines are provided by the center usually. So the problem with in-center hemodialysis, one big problem is, toxin removals. So if you look at the toxin removals with in-center hemodialysis, when the first day of the week, the toxin levels are really high, then, patients get the in-center hemodialysis, and then the toxin levels drop very acutely, very fast, and this often makes patients feel tired, worn out, sometimes dizzy, because there's such a unnatural drop in the toxin levels, and then they slowly build up until the next session, and then you do dialysis again and you drop them again very fast, and then when the weekend comes, then you get a longer period of time where there's 3 days between dialysis treatments now, and the drop again is even more dramatic. So all of these causes problems with the toxin removal. But even probably more importantly, this issue with the toxin removals does not exist with kidney, and when kidneys are working, right? The kidneys are removing toxins 24 hours, 7 days a week, so that you don't have this bumps and troughs like that. So even more importantly is water removal with dialysis. So if you think about it, with normal kidney function, if you assume that you drink 1.5 liters of water per day, so you have to urinate 1.5 liters per day, you divide that by 24 hours, the kidney is only removing about 62 mLs of fluid per hour. But when you come for in-center hemodialysis, if you imagine someone drinking 1.5 liters of water per day, then they gained 3 liters between dialysis sessions, between two treatments. So if you divide that by 4 hours, if assuming somebody is getting dialysis for 4 hours, and a lot of times patients are getting dialysis shorter time than that, then you're removing 750 mLs of fluid per hour. So compare 750 to 62. So if you remove fluid that fast, then the blood pressure tends to drop. There's lots of problems associated with that, and that's one of the reasons why in-center hemodialysis is not always tolerated well. So the benefits of home dialysis is, as I explained, probably the most important benefit is avoiding these peaks and troughs where, with PD at least, you dialyze every day and for long periods of time. So, the amount of changes that happens in the body is much slower, much gentler. And there are other benefits. They maintain the blood chemistries. There's a flexible lifestyle. You can control when you do the dialysis. You're more in control of what you're doing at home. You don't have to come to in-center and wait to be put on, and then wait for transportation to take you back or whatever is the case. It's a better quality of life. Continuous therapy that we mentioned before. With peritoneal dialysis, there are no needles. There is less cardiovascular stress, where the blood pressure don't drop as much, and there's probably more freedom to travel. Peritoneal dialysis patients are often, the potassium is easier to control, so that they can eat more potassium, and there's no need to visit the dialysis center 3 times a week. Other benefits, simpler technique, greater feasibility for use in remote communities, is lower cost, lesser need for trained staff, fewer management challenges during national disaster, possible improved survival in the first few years at least, greater ability to travel, fewer dietary restrictions that we talked about, preservation of residual kidney function, better quality of life, reduced need for erythropoietin or other drugs that are used to treat anemia, and also it's been well established that patients who were on PD had a much lower incidence of getting COVID at the height of the COVID epidemic, because obviously you're not exposed as much to coming. And the last issue with home dialysis is tends to be cheaper. This is actually a study from Europe. I couldn't find one from US, but the number of and this is in euros, but the dollars would be very similar. So the amount of it is also a cost-saving treatment to do dialysis at home, especially with peritoneal dialysis. So the numbers can be significant over the year. So I think that's all of my slides, and I again thank you, and I'm gonna stop sharing, and I look forward to hearing the other talks.
Thank you so much, Dr. Sam. Really appreciate the insight and the overview of dialysis. With that, I'm excited to go on to our next speaker as well. And Evan, would you like to take it away and talk about your
Certainly.
experience?
Thank you, Mary. Um, well, my story goes back to 1972 when I was diagnosed with Alport syndrome. And it's an inherited nephritis, in my case, a mutation on the X chromosome. I found that I had Alport syndrome after a brother got sick, and I had a biopsy in 1972, just before my 10th birthday, which confirmed the diagnosis. In my family, all the boys were affected. Because of the family history, I saw a nephrologist every couple of years as a kid and every year after I turned 16. I have one living brother who's been on transplant or dialysis since September of 1973, 32 years on 3 transplants, and 20 years on hemodialysis. We talk daily and consult with one another about emerging health issues we've experienced over the years. My BP began to rise in 1982, and the nephrologist prescribed a beta blocker. I worked full-time and maintained my medical insurance through my employer, so I would be prepared when the kidneys weakened, as I was told it was inevitable. I also attended college part-time for the better part of 9 years and finished my BA in psychology in 1989. After 6 years of increasing BP meds and as my creatinine slowly climbed, I started PD in April of 1988. And PD was great because it allowed me the independence to continue working and going to college and to do my fluid exchanges on my schedule. I was able to travel widely and simply had my supplies shipped to where I would be staying. I did PD for almost 2 years, then received a cadaveric transplant in March of 1990. Beginning in 1991, I worked as a software trainer for brokers, traders, and other financial professionals. I got married later in 1991, and my daughter Sarah was born in 1993. Unfortunately, the marriage ended in divorce in 1999. The years between 2000 and 2002 were tough as the transplant slowly stopped working properly and ultimately failed in November 2002. I went back on PD, this time with a cycler for another 2 years. From September 2004 and for the next 2 months on, the cycler didn't clear toxins well, and I was slowly gaining fluid weight, and even the high dextrose bags were not pulling much, not enough anyway, just keeping up. I was diagnosed with an umbilicus hernia at the end of 2004, and I had a chest catheter installed in January of 05 and began hemo in center. In July of 05, I moved from New York to Cleveland to help my dad around the house and save on expenses as well. In September 2006, I started a support group in Brook Park, Ohio, that met in a local library conference room. The group is still running with monthly meetings, but they've been on Zoom since COVID hit. We meet on the second Thursday of each month from 7 to 8:30 Eastern Time. If you're interested, email me for more information, and I can send you a link to the next meeting, things of that sort. So we also have a couple social events during the year. Have a picnic coming up this Sunday. We have a Christmas get-together also at a local restaurant. I met another patient, Jenna, and we began dating in 2012 and married in 2018. Sadly, she had had a good deal of heart trouble over the years and succumbed to her 4th heart attack in April 2022. Her grown daughter, Laren, still lives with me. She is my care partner. Until last October, I had been at the same center since 2005. I'd switched to nocturnal when it was offered in February 2010 and began self-cannulating with buttonhole needles to preserve my fistula and minimize aneurysms. And my transition to home hemo with Next Stage. I did my first solo at home with the Next Stage Versi HD machine using the SAC on Tuesday, November 26, 2024. That's the big bag that has the dialysate in it under the machine. It filters house water. So that Thursday was my first solo with hanging bags. I even gave myself 50 milligrams of Venifer. All has gone well. I've had a few alarms, but nothing I wasn't trained to handle. Laren is my care partner and has been trained to do everything I do. I had been considering home hemo from the time Next Stage became available. I had one of the reps come give a talk about Next Stage to my support group in 2015. I was happy, though, with my nocturnal modality. I had excellent results and felt mostly normal with 21 hours of weekly dialysis. I began to talk to people who did home dialysis, and we compared notes. As I compared in-center nocturnal to home hemo, the main advantage for home hemo seemed to be more freedom to travel and being able to set my own hours. But I was living well and enjoying my days on in-center nocturnal hemo. Then came COVID-19. Staffing issues closed the nocturnal shift at my unit in August of 2021. But my unit was able to accommodate the nocturnal patients and their prescriptions on an afternoon/evening shift. So I was still happy doing the long treatments 3 times each week, despite not having all my afternoons free. Further staffing crunches came last spring, though, and 2024. And our last 7 and 8 hour shifts were shut down on Friday, April 12th. I began to dialyze 4 hours and immediately felt the difference. My blood flow had been 300 milliliters a minute of blood for 7 hours and became 375 for 4 hours, and I could feel the difference. It was after that schedule change that I began to plan for home hemo with Next Stage. I had a lot of organizing and cleanup to do in my house, as all three of us, my late wife, her daughter, and me, are all collectors. And we had a lot of things to rehome and organizing to do. Finally, in September, I contacted the Next Stage people for orientation. Our Next Stage training lasted from mid-October until late November. The last 3 days were with a nurse at home. We trained on the same machine I would be using at home. The training was thorough and well planned. I was told to forget about in-center, that this is a completely different animal. The prescription was also quite different, and there are safeguards to improve the experience and simplify the process. For example, less heparin is needed due to the closed circuit of tubing that includes the dialyzer. The best part of the Next Stage Versi HD with Guide Me software, which I use, is the Guide Me part. The machine's touchscreen shows step by step how to go about setting up and getting on the machine, and in dealing with caution alerts and alarms. It reinforced my memory at every turn, building my confidence quickly. One home hemo factoid is that you can dialyze solo or with a care partner. It depends on your independence and current everyday life skills. So my first Next Stage delivery came about 2 weeks before I started at home with PACs, the house water purifiers, and sacks to make the dialysate from concentrate, and cartridges, drain tubing, and hanging bags and tubing. Now, they also send out all the medical supplies you would need, such as gauze, tape, and so forth. You have to have a place to store it. The Biomed installer brought the Next Stage Versi HD machine to my house Monday the 18th. I went home with the nurse that Thursday, and my first true solo was on Tuesday the 26th. My first prescription was 3 hours, 5 days each week, with blood flow set at 350 milliliters a minute. In May, I transitioned to nocturnal with Next Stage. My prescription was 7 hours at 300 milliliters a minute blood flow every other night. I seldom need binders, and my diet is very similar to what I could eat on my transplant in its prime. I've only done home hemo since the late fall of 2024, and I've already taken a few car trips to visit my brother in New Jersey. You just have to strap the machine in a soft case in the back seat with a seat belt. Anyhow, I'm planning a longer trip by air to visit friends on the West Coast. The freedom to get my therapy at friends' houses and hotels is a big advantage over hoping to get an in-center chair near my destination, which since COVID has been a more complex arrangement, and also harder to get yes answers, whereas it used to be pretty simple when I would travel before COVID. So more frequent and longer dialysis sessions give me more energy and a better sense of balance in my life, with many more choices open to me. Isn't it all about feeling normal, whatever that is for you? Jenna always said that normal is a cycle on a washing machine and means different things to everyone. With dialysis, longer treatments are better for your heart. You seldom feel toxic. I should say with nocturnal dialysis at home, longer treatments are better for your heart. You seldom feel toxic, and treating on more days also eases the fluid burden on your vascular system. And you begin to feel stronger and more alert with less side effects than normal chemo in center. Normal kidneys are working 24/7, but dialysis is my job. And that's the whole thing.
Thank you so much, Evan. Really appreciate your insight and sharing your story. That was really phenomenal. And we're going to move right on. I know we're got like a half an hour, so we want to make sure that we can get a few questions at the end, because I'm sure there's a lot of folks that are kind of wondering, like if you are, I don't know how many people are on in-center hemodialysis and how many people are transplant or, maybe earlier stage kidney disease. But I think the main thing that we really want to get across here today is kind of sharing our story so you don't feel alone. And I think Christina and Michael are going to share their journey. And Christina is a veteran, and the only thing I can say about Michael is like he's the amazing care partner. I keep saying I'm going to loan him if I need a care partner in the future. So Christina, you got to watch out. You better hope I don't end up back on dialysis. So thank you so much. But with that, I just want to say thank you again for attending tonight. And with that, I'll turn it over to Christina and Michael.
Okay, so Christina's story is so in-depth that I'm going to give you the Cliff Note version so that she can concentrate more on the home dialysis stuff. Okay, she was diagnosed at 12. She was told that she had a kidney disease, said don't worry about it. And at 22, she got pregnant, got toxemia, and she ended up having seizures, which ramped up her kidney disease. Her kidneys failed. She lost her eyesight during those seizures. And fun fact that she bit off her tongue as well. But you can learn more about that later on. And then, so she was in total kidney failure, and she ended up getting a transplant from her brother. She had a fistula replaced. She only had to do about a month of dialysis. She kind of jokes that it was a drive-through kidney. And unfortunately, that one failed 1.5, 2 years in. And she had to do 6 years in center. All of this while she was a young mom and young single mom. So she had to take her daughter to dialysis. She was told she can't do home because she's legally blind. And she got that call about 6 years after doing in-center and was told she has another kidney. That is when I came into the picture, and that kidney lasted about 1.5 years, 2 years as well. She started rejecting. We tried absolutely everything to stop the rejection. She even tried some chemo meds. But we had to give up on that kidney, and she ended up, and Christina, I'll let you take it from there.
Can you hear me?
Yep,
Can you
go
hear
at
me?
it.
Okay, just so you know, you passed it over right as I have to sneeze. So if I have to sneeze, then I'm sorry. But that's actually really funny hearing my story being told from someone else. But yeah, so that is my story. I've kind of been in this almost my entire life. What I really noticed about the different modalities is I've experienced every single modality that there is. And I feel like I kind of, with each modality, I got more educated, I got more knowledgeable. And to be honest, I learned how to manage my own body better. And so, like, when I was in center, I did 5.5 years in center. And for me, it was a rough time for me. I was a single mom, legally blind. And so that means I can't drive. And so for me, like most people can go to dialysis and then go home and relax and recover. Well, I didn't have any time to recover. And so for me, like an average day of dialysis was go do dialysis, come home, walk a mile to my daughter's school to get her from school and walk her home, and then say it's soccer practice day. And of course, I overdid it and put her in everything because I didn't want her to think she didn't get to participate in stuff because she had a sick mom. So she was in everything. So then it was like walk a mile the other way to soccer practice, and then you get home and your day's not done. You still have to make dinner, and you still got to do homework and showers. And my days were literally just go, go, go. And I was in my 20s, so I literally watched all of my friends, everyone around me, I watched their lives continue. I watched them get married, go on trips. And I felt like I was so restricted in center. And so when I hit that 5.5 year mark, I was really contemplating quitting. And I was really lucky to get that phone call. So I jumped on that kidney and got that second kidney transplant. And that's when I met Michael. And shortly after I met Michael is when I found out that I was actually rejecting the second kidney. And I actually had disease reoccurrence. I didn't know it at the time, but it was disease reoccurrence on the second kidney as well. And so unfortunately, we fought it for a while, but that one failed. But I decided that in center for me was just, it just seemed so unlivable. And so I decided that I had to figure out a way to still keep my life that I had and I had now like been able to maintain for a bit. And the only way to do that was to figure out how to go home. And so Mike and I started researching PD, and we researched everything, and I decided I'm going home on PD. And so unfortunately, I had to go to 5 different doctors, and every single doctor told me I was legally blind, I can't do home, and told me I couldn't do it. And so I was pretty persistent, and because I kind of knew that in center, it me and in center just didn't mix, and it did have a horrible effect on me. And so I knew to live and be the mom I wanted to be the partner I wanted to be, I had to have something. So I went back to my 12-year-old doctor, and I just broke him down until he taught me how to do PD. And when I went home on PD, guys, like I always say PD for me was life. And truly, I feel like PD gave me life. It was the first time since all of this went down that I truly felt like a human being. I felt like I could wake up in the morning and live like everyone else. And PD, we started traveling. I flew with PD. You fly with your machine. We have some property. We live in Utah. We have some property in the mountains, so we go camping a lot. We don't have power at that property. So Mike put his his genius mind to work, and he started with solar panels, connected it to 2 car batteries and an inverter, and we did dialysis in the middle of nowhere with no power. And how incredible is that? Like I truly felt like on PD I could live. I got married on PD. Um, I I did so many things on PD that just I never thought would ever be in my life. We went on a honeymoon. After doing PD for 3 years is when I found out I had abdominal adhesion and I was no longer able to do PD. So that's when I was really lucky because about like 6 months before that, I had heard about home hemo. So as soon as I heard I was no longer a PD candidate, I was like, okay, when do you get me to home hemo? Like, let's start training. So Mike switched to nights and we went to home hemo. And for
Well,
us,
before we started doing that, I found that there wasn't many support groups for the care partner out there. And I was watching my wife get sicker and sicker and sicker doing PD because it wasn't filtering correctly. So she ended up having to go back in center. I could see how miserable she was going in center. I had to put my career on hold. I'm an aircraft mechanic and I was driving at that time, but I had to put everything on hold because I didn't know if my wife was going to make it to the next day. So when I had to become her eyeballs for home hemodialysis, I told her I'm gonna start a support group because I was getting sick and tired of getting answers to problems after they happened. And it's always that, well, yeah, that could happen. I'm like, well, why didn't you tell me that 6 months ago? And Christina, if you know us online, Christina wanted absolutely nothing to do with the online group. She didn't want anything to do with it. And I said, okay, fine. There was a picture of her doing dialysis on a motorcycle. We got stuck in traffic. We had to do what we had to do, but it kind of went a little viral and people started knowing who Christina was. And I would go to work for 10, 12 hours, sweating underneath an aircraft, going to training and then still having to perform dialysis on Christina, and I was running on empty. And then I would come home and I would just be on my phone nonstop, asking her questions. Oh, hey, what do you do about this? What do you do about this? What do you do about this? Till finally she started seeing how much of an impact that Christina was having with the kidney community. And our group is called Living on Dialysis. She quickly got known as Blind Chick Living. I became the caretaker, and that little tiny group that I started a couple years ago is now 13,000 people. And follow us on social media. We have all social medias, but go ahead, Christina, tell about home hemo.
When we actually started training, that's when he started this group, and we actually trained very quickly. We forced ourselves because I really wanted to go home. So we actually trained within 3 weeks. And when I first went home, I was doing 3.5 hours, 4 days a week. And guys, I thought PD made me feel good. Hemo it literally made me feel like Superwoman. Like I went back to the gym. Like I wasn't just normal anymore. Like I was thriving. And like hemo, the only thing about it that was difficult was fitting it into our schedule with Mike working all day and then him coming home right to dialysis, and then after dialysis, dinner in bed, that's your day. And so I wanted what I had on PD. I wanted to be able to do it during nighttime and not have to worry about during the day. So after doing home hemo for a year, I switched to nocturnal home hemo. And guys, my schedule is 4 days a week. I do 7.5 hours of dialysis. So I get 30 hours of dialysis, and we run at 250. And so we run really, really low.
And I'll kind of jump in real quick on the care partner side of that. I got my life back as well. I had to stop promoting at work and all that stuff while we were doing home hemo and training everything. But being able to sleep during dialysis and actually being able to do treatment when we want, I can say I'm not sweating underneath an aircraft anymore. I'm actually an engineer now. So I sit at a desk and tell people how to sweat underneath the aircraft. And I got my life back doing home hemo and nocturnal. And I know it scares people beyond belief. And that's why we have support groups. That's why we have things like Evan's support group, our support group, because as a dialysis patient, you feel alone. You feel like you're the only person going through this. And all I can say about that is come in, ask the questions, because you think you're alone. I can find hundreds of people that are going through the exact same thing as you. And it's a great place for the community to see how people are camping, how we set up the property to do dialysis, just doing all of that stuff and thriving. And you can see how peppy Christina is. If you have ever tried to argue with a dialysis patient about not going to the gym, I'm tired on the weekends. It's impossible. So she's living proof of what home dialysis can be.
And that's just it though, guys. Like when I started nocturnal, they say it's the closest thing to having a cadaveric transplant. And I can tell you, for me, I feel better than that. I feel amazing. My diet has no restrictions anymore. I don't take binders at all, ever. I literally I was looking into becoming an advocate before I had started nocturnal. And when I started nocturnal, it was like, hey, there's nothing to stop me now. I feel like I can go, go, go. We travel now, and we try to travel at least once a month, and we try to get the word out about home hemo and let people know that not only is this like making me feel better every day, but I truly think it has allowed my body to get stronger. I feel like I am healthier today than I have been along this entire journey. And I'm at this 21 years, and truly, I feel like I'm just getting started now.
Yeah, and we don't know if Christina will ever be able to get another transplant. With her disease recurrence on 2 transplants, we don't know if we're willing to take that chance yet. There's a lot of meds coming out, so we fingers crossed. But with this modality, there's no studies showing life expectancy on home. We know people that have been doing home 30, 35 plus years, and just while we were talking, I set up the machine, and it becomes second nature. Me and Christina, we have adult kids now, we have grandkids, and we sometimes argue about dialysis, and she
wait.
gets overwhelmed and stuff.
Wait, Mike.
But
Did you guys
one of the
did you guys
things,
did you guys hear that? We have a grandbaby. Yes, I'm a grandma now. Like I literally at 22 was told I had 6 to 7 years. I'm a grandma, and I know that finding home is the reason I'm still here today.
and we have very hectic lives. And like I said, sometimes Christina gets a little overwhelmed with all the dialysis stuff and medical, and I have to sit her down and make her realize dialysis is the easy part of our life. It's all the chaos, the grandkids, the kids that we don't have control over. And when you sit back and look at it, this is the easy part. Setting up, going to sleep. Is it tough? Absolutely. Is Christina struggling on a daily basis? Sometimes. But she is the healthiest that I have seen her, and there's no stopping. I know Mary wanted to do some questions. Christina, if you have anything else to add, and let's go ahead and do questions. And Mary, take it over. And Mary, you don't have to be on dialysis for me to come be your care partner and all that stuff. So
There you go.
I'll do it anytime.
Thanks, Michael.
I'm gonna start like renting him out as a care partner.
Thank you all for, I think we really had a great opportunity of, Dr. Sam actually shared all of the options for dialysis. And I think that's really, I think you heard many stories here today talking about, what worked for them. And I think, it's really an individual choice. And I think that's the big thing that we're talking about here right now is really that it's your choice and what works best for you. Some people do fabulous on in-center dialysis. Other people do better on peritoneal. Other people do better, on hemo at home. So I think, really I think what we are really, I think one of the things that I heard, front and center here is that, what gives you best quality of life? And I think that's what we really want to do. And that's why we're sharing these stories today, why Dr. Sam went through and talked about the different options. And I think that, again, it's not a one size fits all, but you'll hear some wonderful stories, from what Christina shared to Evan shared and Michael as a care partner and how they felt with the different types of modality. And how they did that. So I wanted to share that is that, again, if you are in a different place right now in your kidney journey, whether you are right now facing possibly dialysis or a transplant, I think, as Michael said, is you're not alone. There's many of us out there and that really want to help support you as well, that we've been on those journeys for a long time. And some people are just starting that journey. So with that, I'm going to open it up for questions. I don't see anything right now in the chat. But please, if you can't find the chat, just raise your hand and we can try to get that for you, and then we will try to answer that. But I do see Lisa. Home hemo is a way to go to have normal
Active.
Oh, active. Married or single. Transplantation is not always the best fit long term. Yeah. So again, I think that's you'll hear from different folks of what is best for them.
I will also say too that we're on all social medias, so questions come up usually after all of this stuff. If you just Google Blind Chick Living, you'll see us everywhere. Reach out and we can put you in contact with ESRD and all that stuff. Sorry, Mary, go ahead.
Oh, no, absolutely. So again, I don't know if we have any other questions. One question I do have for the audience is, do we have anyone who's on the early start of their journey with kidney disease? Do I see any hands? Okay. And do you have some questions? I'd like to open it up.
I saw a question in there about peritoneal dialysis and how often that catheter needs to be changed. That is basically up to the patient because it all depends on how well your treatment is going. I know people that have had the same catheter for 5, 10 years. Sometimes it needs to be changed out, sometimes it doesn't. Christina has actually had a PD catheter in her chest and in her stomach. So there are all multiple places you can place it. And as long as you're taking care of it and you're practicing hygiene safely, it can last however long as safe as you can be.
Thank you. So some of the folks that are on the call, since you're new on this journey, do you have any specific questions that we've got some seasoned people here that might be able to help with some of those questions?
I know there was a comment in there about a blind patient and how she gets support. Reach out to me. Okay. Just find me on social media and I can put you in contact with Christina. She is one of the best people to talk to, especially when there's site limitations. And don't be scared. Ask the questions. That's why you're here.
Any other questions?
There is a question, Mary. Where do you perform nocturnal dialysis? In a recliner?
Yep, thank you.
Christina, do you want to take that one?
Sure. You can do it wherever you want. You could do it on a couch if you wanted, in the chair itself. I actually do it in bed. I just hook up and I go to sleep. And so that's easiest.
Yeah, you can actually see all set up actually right now. There's the bed. We have adjustable beds, so we can adjust her and sit up for if she needs to adjust her blood pressure or anything like that. And the good thing about nocturnal is you actually only do blood pressure twice. You do it right when you connect and when you disconnect. And then there's some while you're setting up and everything. But you can do it in a chair, you can do it in bed. What I kind of tell people is give yourself about 1 year of doing regular home hemo just so you can get used to the alarms and all that stuff, because that was one of my biggest fears is, am I going to wake up to this stuff? And with the additional sensors and alarms and a heparin pump, you're not going to sleep through the alarms. You won't have an issue with that at all.
Yeah, my experience with where you can do at home, basically do it in a bed. I did it in my brother's sofa bed when I visited him. I do it in a chair. They provide you with a chair, just like a dialysis unit. And so there's lots of alternatives. You can do it sitting up on the couch if that's your, preference. And now that I'm doing longer treatments, I just kind of have some extra safety features set up so that I won't have the needles pull while I'm sleeping. And my daughter keeps an eye on me. I sleep half the shift, she sleeps the other half, kind of thing. And that's so you just make it fit for you, and it will work.
Me and Michael actually, we both sleep during my treatment. So we hook up and we both go to bed. And so we both know the alarms. And if one of us doesn't get woke up, then my daughter will next door. But we get woke up. The alarms are very loud, and there's definitely some adaptive stuff to make it to where you're not unsafe with this machine. And this machine, guys, it is not a in-center machine. This is a home machine. It is designed for patients. So this machine, it is honestly so intelligent, and it's, for the most part, if you got like air in your line and stuff, it will not let you keep going. Like it will just yell at you until you finally give up, because it literally, this machine knows what it's doing and it's designed for us. So it's not huge. You can fit this in your house. You could even push all of these supplies into a closet and no one has to see it. So my thing is just don't let this be an overwhelming process. Sit back, watch how others have done this, and just slowly take this literally a day at a time. Try not to look too far into the future, and just know that your modality will change throughout your journey, and your access will change. I've had every different access. I've had a CVC now for 3.5 years, which is super bizarre, but it works best for me. And so honestly, like, be open to knowing that things will change. You will need certain things throughout this journey, at certain times, and other times you won't. So just know that, be flexible with this. Just know that, like, be willing to make changes, to make improvements, to make changes. So yeah, good luck.
I have something to add, and that is the attitude of the patient. As you can tell, Christina is bright sunshine, and Michael is bright sunshine. And you know, the biggest thing about success in any dialysis endeavor is your commitment to doing things the way you're taught. And whether that's in center and, you know, not waving your arms all over and making a ruckus, or it's at home where you have, you know, some control. My chair is facing the television. I've watched some great baseball games, and my daughter, for example, gets rolling her eyes when I start yelling at the umpire, for example. You know, so it's your life. You're living your life while you're dialyzing, even if you're stationary. You know, I mean, what they used to call with CAPD, the A stands for ambulatory. So you're just wandering around in your life. And I did all my, you know, schooling, and I would just make sure I had a break so that I could every 6 hours change out to, you know, change out another 40 minutes for me to drain and fill. And I would do it in the locker room at work, and while I ate my lunch, I would do it in my old Nissan Sentra with the bag hanging from the mirror. So, you know, there's so much that flexibility allows, as long as you follow careful rules of cleanliness and aseptic technique. You can really, the sky's the limit. I did PD on the floor of the House of Representatives when my girlfriend was doing a Convention 2 reunion in 1990. I guess it was 1990. And Christina, as she said, did PD on a motorcycle, which sounds fun. That sounds fun, Christina, really. You know,
Well, probably not the safest thing, but yeah, we did make it as safe as possible. And like you're saying, like, I want to be like, when I do die someday, I want to die living out and experiencing the world. I don't want to be in a center just not being able to live properly. And so that's why I do this. That's why I push myself out of my comfort zone. But I like to tell people, we all had to switch our career some point in our life. We were able to be trained. We can be trained again. So just take this training, take it slow, and just know, if you are already thinking of skipping steps when you're in training, you should probably not go home, because you do need to take this serious and remember that these steps are there for a reason, and they are all important.
And we're running out of time, so we'll just say real quick, and I get a lot of pushback on this, but if a blind chick and a dumb mechanic can do this, anybody can. So reach out, get the help you need. Mary, back to you.
Thank you so much. I just want to wrap up and say, I think you had a great opportunity tonight to really hear the different modes of dialysis and different types of treatments. And with that, we will be having another webinar, and that is going to be on September 23rd, talking about another mode of treatment, which is transplantation. I hope you can join us with that. You'll hear from some folks that are going to that will discuss more about transplant and their perceptions and their experience living with a kidney transplant. With that, I'd also like to make sure that you please do fill out the survey. This is how we become better at what we do. And we also make sure that we're on the mark to be able to help and support you. So thank you again for a great evening and a great conversation. Appreciate every single one of you for joining us tonight. And with that, have a fabulous evening. And thank you again. Good night.
Right.
Good night.